Thank you all for joining us today for this wonderful presentation by Dr. Jeter. And she's going to talk to us about the management of joint pain. And she comes to us with a lot of very, very high credentials and very impressive. I'm going to let Dr. Jeter tell you a little bit more about herself. And before we start, I just want to thank everybody for coming, and I want to thank Dr. Jeter in advance for doing this for us. Thank you.
Thank you very much for having me. So my name is Chrystina Jeter. I was born and raised in the Central Valley of California and did my medical school training at UCLA and my residency in anesthesiology and a fellowship in pain management at Stanford. I recently joined orthopedic surgery specialist at the beginning of 2021. Prior to that, I spent about 5 years working for UCLA, doing acute and chronic pain management for them. So thank you for having me. Today, we're going to be discussing how, as a pain management doctor, I'm not a surgeon per se, but how do we manage joint pain non-operatively? And so any questions that you have, feel free to put them in the chat and we can discuss them afterwards. Okay, so a little bit about joint pain. So musculoskeletal pain is the most common type of chronic pain worldwide. And of the musculoskeletal pain, knee joint pain is by far the most common. Approximately 52.5, I think that number is a little higher now, 52.5 million adults have a diagnosis of arthritis. And about 50% of those people have some kind of significant functional limitation due to their arthritis pain, be it difficulty completing activities of daily living, working, caring for themselves or others. So it's a big deal and it's something, a very important issue that most of us tackle every day. A little bit about joints. There are several different types of joints throughout our body. And this is just a selection of those, the most common ones. In the upper left-hand corner here, you can see that, excuse me, one moment. So there are plane joints, which are located here in the lumbar spine area, and it allows your spine to do a little bit of shifting and bending. Those particular joints are called facet joints. There are hinge joints, most commonly found in the elbow, very stable joint. Ball and socket joints, the shoulders and the hips. This is a more unstable joint because you need your shoulders and hips to have a wide range of motion. So this is a less stabilized joint and sometimes more prone to development of arthritis. Here in the upper right-hand corner, a saddle joint, the base of the thumb, where the thumb attaches to your wrist, is called a saddle joint. Again, a rather unstable joint because you need a lot of flexibility and mobility in that particular digit. A pivot joint, which is the joint that's here in the lower part of your forearm. It allows you, for instance, to carry a tray, but then also dump that tray into the trash. That's that motion, that's a pivot joint. And lastly, ellipsoid joints, which is the joint that attaches the top of your cervical spine to your head and allows all of this motion. Very important joint. A little bit about joint anatomy. So joints are merely the areas where two bones that need to stay together actually come together, and it's the tissues that hold that joint and those two bones together. So starting on the inside, if we work our way from inside out, this ribbon of blue here, this is called articular cartilage, and it's merely like a shock absorber. It's what protects the end of the bone from the other piece of bone here. This is the area where osteoarthritis and rheumatoid arthritis tend to start. And it's the breakdown of this cartilage that leads to the pain and dysfunction associated with arthritis. Inside of here, this lighter blue is called synovial fluid. This is the fluid that acts as the lubricant for the articular cartilage, and it allows a nice, easy gliding joint with no friction and, most importantly, no pain. The synovial membrane is this wavy thing here. That is the membrane that actually secretes the synovial fluid into the cavity. And just outside of that, there's a bit of a fibrous capsule that sort of holds all of this together and holds the fluid inside. And outside of that is the ligament. These are very, very tough pieces of tissue, and it's actually what provides most of the stability of the joint here. So you obviously don't want any damage to the ligament either. So arthritis and joint pain tends to occur in some pretty key places throughout the body. It can technically occur anywhere, but these are the most common areas. The neck or the cervical spine is quite common for osteoarthritis of the spine because it supports all the weight of your head, primarily at the lower segments of the cervical spine. Likewise, the low back or the lumbar spine is another very common place where we see osteoarthritis of the spine. And that's because it is supporting all of the weight of your upper body. The hips, the hips and the base of the thumb tend to be more commonly affected because they are slightly less stable joints because they need a greater range of motion, and because of repetitive use for walking everywhere, using our hands to do any kind of task. The ends of the fingers can sometimes be affected quite a bit, and that's typically because we need our fingertips in order to be dexterous and do fine motor tasks. The knees, again, typically affected because they are supporting the weight of most of your upper and lower body. And the base of the big toe is a less commonly, people don't think of it as being a common area for arthritis, but it is because when you're walking at certain points, the way you step off and initiate your next step, you are actually putting the total weight of your body on that joint. So there are many different causes of joint pain. We are going to focus primarily on osteoarthritis today because it is the most common. But there are rheumatologic causes for arthritis and joint pain. And this is just the most common causes: rheumatoid arthritis, lupus, psoriasis, and inflammatory bowel disease are some common systemic conditions that down the line can result in arthritis, mostly due to inflammation. These things rheumatologic causes of arthritis, you tend to be diagnosed with earlier in life, somewhere in the 20s or 30s. Gout and the deposit of crystals into the joints can result in rather severe joint pain when flares occur. Bursitis is a common cause of joint or the perception of joint pain. Bursas are these small fluid-filled sacs that cover the outer surfaces of major bones. The hips, the knees, the elbows all have bursas associated with them. And if you get inflammation of this bursa, you can have quite a bit of pain. There's infectious causes as well as sprains and strains that can cause. Sprains and strains would mostly be damage to that thick outer ligament that we saw on the outside of the joint. So with osteoarthritis, it's a progressive degenerative joint disease. We already kind of reviewed the joints that are most commonly affected by it. And the cause of it and the start of osteoarthritis is damage to those little shock absorbing cartilage pads that are sitting on the outsides of the joints that are coming close to each other. That damage can occur from an acute injury, of a significant fall, motor vehicle accident, a history of being a professional athlete, or some kind of high impact activity that's done regularly. And it starts though with damage to that shock absorber cartilage. And then after you get that damage, you start to have a slow sort of deterioration of that cartilage. Once the end of the bone starts to notice that there's more friction and more pressure on it, your body will start to thicken that end of the bone where that cartilage is deteriorating. And you'll start to form what we call osteophytes and are more commonly known as bone spurs. And that's just your body's reaction to that damage and to the deterioration of the cartilage. And those bone spurs can also be painful in and of themselves. After that, you start to get inflammation of the synovium, which is that inner lining of the joint capsule that produces the fluid that you need inside the joint. And as inflammation results in decreased production of that fluid. And so as that happens, as the cartilage is deteriorating, there's less fluid, those bones are getting closer and closer together. And ultimately, you'll start to notice damage to the soft tissues, to the ligaments on the outside, the joint capsule, and that's just a result of the loss of cartilage, the loss of fluid in there, and the decreased stability of the joint itself. And this process happens typically over several years, if not decades. So it's not typically a very fast process. This is just a schematic of what a normal knee would look like if we opened it up for surgery. It's got nice smooth, the cartilage is actually quite shiny when it's healthy. The ligaments themselves are nice and strong and bright white colored. On the right side here, you can see that there's the development of some arthritis in this joint, and we'll see some breakdown of the cartilage here, and sort of some fraying. And these pieces of cartilage can actually flake off, and sometimes the surgeons will find them floating inside the synovial fluid during surgery. There can be damage to the meniscus here, which are these little cups that provide stability to the joint, as well as those bone spurs that can form both inside the capsule as well as outside the capsule. And in either location, they can be painful. So I'm usually asked, why did this happen? Why am I developing arthritis? What are my risk factors? The primary risk factor for the development of it is aging. As we age and we use our joints over decades, that articular cartilage, it doesn't have a very good blood supply. So it doesn't heal itself very well if you do have an injury or with repetitive use of that joint. The cartilage over decades will start to thin. And as we get thinning of the cartilage, reduced hydration of that joint, it can result in some brittleness of the cartilage and the bone itself and allow development of those osteophytes and calcium deposits. Joint injury, again, very important cause after aging. And that usually results in damage to the ligaments and meniscus or any fractures. And that causes instability of the joint, which can start the process of inflammation and deterioration of that cartilage. The other important thing to notice is some people will have no pain, and then they have some kind of an injury, a fall or some kind of mechanism of injury. And they'll notice that from that moment on, suddenly they have arthritis pain that they didn't have before. And that's typically because that one joint injury causes an acute inflammation, which results in release of these inflammatory markers, which accelerate the process of degeneration. Obesity is another very important risk factor to discuss, and that's purely based because it causes increased force on those weight-bearing joints. I always remind my patients, if you can lose, if you are obese or have a diagnosis of obesity, losing even 5 pounds can be really helpful in terms of reducing the force on those joints, particularly the knees and hips, as well as the lumbar spine, and can really help improve your pain. A secondary reason for that is adipose tissue produces inflammatory mediators or inflammatory markers, which kind of results in this low grade smoldering level of inflammation throughout your body. And if you already have a joint that has a little bit of inflammation in it and a little bit of degeneration of the cartilage, the extra adipose tissue will will only potentiate that and make it worse. Lastly, there are genetic factors. Those typically are diagnosed in adolescence and can be quite severe. There's some anatomic factors that can also predispose you to development of osteoarthritis. The shape of your joint, if it is abnormal in any way, can result in arthritis at an earlier age. The most common example of this is in the hip. Untreated congenital hip dysplasia, which my daughter actually had. She wore one of these little harnesses for about 4 months after she was born. And her hip joints formed during that time around the socket, and she was perfectly fine. But it wasn't that long ago that we did not screen for this in certain babies, and people were coming in for hip replacements in their late 20s and early 30s. Joint alignment is another important risk factor to look at. What we sometimes will refer to as bow-legged or varus deformity of the knees can result in unnecessary or additional stress on the inside portion of the knee joint and result in more arthritis. And conversely, what we call valgus or a knock-kneed appearance can result in additional force stress on the outer aspect of the knee joint. Gender is a less common risk factor. We know that hand and knee arthritis is more common in women, and hip arthritis has a relatively equal prevalence. When we diagnose osteoarthritis, we primarily are looking at signs and symptoms, so the history and physical portion, and pain. That's the primary thing, is people point to that one joint where you've got this terrible pain that worsens with use, improves with rest. Sometimes will worsen in cold weather or improve with heat or warmer weather, drier weather. Can range from dull and sharp to achy. Doesn't usually radiate far outside of the joint itself. There's usually a significant and exquisite tenderness over the joint line itself when we press, and crepitus, which is kind of a crunchy sensation, can be noted when you're bending your knee to put on your pants or whatnot. You may feel, or even in the neck, some people will describe hearing kind of a popcorn type sensation in their neck. That's a little bit of fraying of that cartilage sensation that you're sensing. It's not dangerous, but it can sound and feel kind of dangerous. There's reduced range of motion of the joint, and that's usually because of inflammation. There can be swelling of the bone, as you can see in this picture here. And joint deformity and instability are also important things that we look for. If we have a reasonable suspicion of osteoarthritis, we will usually get some imaging that starts with x-rays. And I'll show you an example. We're looking for narrowing of the joint space. You can see bone spurs. You can sometimes see cysts. If we're really not sure, if we're trying to identify the acute inflammation part of the osteoarthritis, and the x-ray might be normal, but we still have a strong suspicion for it, we can get an MRI, which can detect that inflammation a little bit sooner because we can see more fluid, we can see more soft tissue on MRI. And in particular, we can look for cartilage defects that might be present, as well as large accumulations of fluid or effusions, and abnormal synovium or cysts. And rarely we'll use ultrasound if we're looking for more soft tissue or fluid pockets within the joint, but that's a little bit less common. So this is an x-ray of one knee joint that's completely normal. You can see this little mustache line here. That is a sign of good cartilage presence. We cannot see cartilage on x-ray. It's clear, but we can see that, considering there's a nice thick line of missing tissue here, and between the bones, that there's probably adequate cartilage presence there. On the other side, on the patient's left knee, you can see that that little mustache line doesn't quite look the same. And these two bones are very close together. That indicates to us that the cartilage here is absent, it's gone. And so this is probably where most of their pain is and the cause of most of their pain. This is another x-ray that just really shows what osteophytes or bone spurs actually look like. And they just look like haphazard little bony segments that are growing usually off the tips of the bones here, but rarely they can be here in the center. Sclerosis is just an extra hardening of the bone in the presence of arthritis. And this is an arthritic hip. The left hip here, again, when we're quickly looking at x-rays, we're looking for a nice thick strip of black here that indicates that the joint space is open, that there's cartilage there. And you can see on the right side here, that joint space is much more blurred. There's some osteophytes, there's some bone spurs. And here you can see some sclerosis or hardening of the bone. And so I imagine this person was in a lot of pain in their right hip. Lastly, we can sometimes do a synovial fluid aspiration. So actually aspirating the material, the fluid out of the joint. This is more commonly done if we're concerned about either infectious or rheumatologic causes of arthritis. And we will send this sample of fluid for testing to look for unusual white blood cells, red blood cells, protein crystals, if it's gout, something like that. So the treatment options for osteoarthritis. It ranges from mild or more what we consider conservative treatments all the way up to surgery at the very top. We're going to be discussing the things that are below the surgery triangle. But typically we're going to start with things that you can do at home. Making sure that you have adequate exercise and therapy, considering weight loss if it's needed. We'll discuss nutraceuticals, embracing. The next step up from that would be, again, over-the-counter medications, as long as they're safe for you. The next step up would be things that we would have to do in the office, either prescription medications or injections. And the pain management aspect of this really kind of traverses from mild to severe. And we'll talk about the different types of injections that we do specifically. So number one, far and away, the most important treatment that I prescribe for my patients is physical therapy and exercise. We have excellent physical therapists within OSS, and their slogan is motion is lotion. So if you don't remain active, if you don't maintain a daily home exercise program that keeps your joints moving and the muscles that surround them nice and strong, then you'll notice that your muscles will start to atrophy, and that's when the pain really sets in and can be difficult to manage at times. If therapy and exercise are really hampered because of your pain, topical options can sometimes be helpful. Lidocaine patches in either 4 or 5%, 5% as a prescription strength. Capsaicin cream, which activates a substance in your body called substance P, and which can reduce your pain temporarily, can sometimes be helpful for arthritis. Topical NSAIDs like diclofenac gel or Voltaren gel, which is now available over the counter, is sometimes helpful. And CBD, which we could do an entire hour talk on. The benefits of it. CBD is sometimes helpful for osteoarthritis. The research is still in its early phases though. But I usually advise my patients, if they're interested in it, to give it a try. The price can sometimes be a little bit interesting with CBD. So with oral medications, there are some nutraceuticals or nutritional supplements that have some data to support them. I've only listed the ones here that do have data to support them. So turmeric or curcumin, which is the active ingredient in turmeric, does have actually rather good data to support its anti-inflammatory benefits. And it tends to be pretty well tolerated in most people with relatively few side effects. And so that's a pretty common one now. I see it in a lot of supplements and foods for that matter. Green tea has a lot of antioxidants that are excellent for helping to slow down the breakdown of tissue. And it's also been the alpha lipoic acid and L-carnitine, which are in green tea, have been proven to be helpful for neuropathic pain as well. Fish oil is another one that there may be some data to support it. It's healthy, it's good for your heart, but we also think there may be a component of it that's helpful for chronic pain. Magnesium, we know that people with magnesium deficiencies tend to have more irritable nerves and tend to be more prone to development of chronic pain. And again, in normal doses tends to be pretty well tolerated in most people. We also use magnesium sometimes to help prevent migraine. And vitamin D deficiency has been implicated in chronic pain. You know, the research does not suggest mega doses of vitamin D, but whenever anyone comes into me with kind of an arthritis type picture, if we're getting lab work, we typically will check a vitamin D level. NSAIDs, ibuprofen or Aleve, which is naproxen, Motrin, those are all over-the-counter NSAIDs that are good places to start as long as you tolerate them. Meloxicam is a prescription version of an NSAID, a little bit more powerful than ibuprofen, usually a little bit better tolerated. Acetaminophen or Tylenol in higher doses, in more arthritis strength doses, which I believe you can actually purchase arthritis strength acetaminophen now. Works for some and not others. COX-2 inhibitors. So Celebrex is the only one left on the market now. There were a couple of others that were removed from the market in, I believe, the late 1990s due to cardiovascular events. But Celebrex was not associated with any of those issues and stayed on the market. Regularly, my osteoarthritis patients either come to me already on this, or we do try this on them at some time, as long as they're good candidates for it. And it can be really helpful. Lastly, if all of the above fails, in an effort to avoid opioids, we will try SSRIs and SNRIs, which the most common of them is duloxetine or Cymbalta. These are antidepressants. When Cymbalta hit the market, you know, in part of their post-production research, they noticed that people who are on Cymbalta noticed that they didn't have as much hip joint pain. And so they actually took Cymbalta back and studied it specifically for osteoarthritis and got an FDA authorization for it. So we do frequently use Cymbalta for arthritis pain and for nerve pain, for that matter, in appropriate patients. So this is a good stuff. This is what I like to do, injections. If all of the aforementioned treatments are ineffective, then usually our next conversation is about injections of some kind or procedures. The most common of which is cortisone or steroid injections. A lot of people do these: primary care doctors, surgeons, pain management doctors. And really, we just put a shot of cortisone into the affected joint, and we hope that we are able to dampen those inflammatory mediators and calm down the pain. They typically work for about 3 to 4 months at a time, sometimes longer if you're lucky. As that process of degeneration continues, though, they tend to stop working over time. Our next step will be, if cortisone doesn't work or loses its effectiveness, would be hyaluronic acid. Hyaluronic acid is in every skincare product nowadays, but it's also a key component in synovial fluid. It provides all the lubrication and viscosity inside the joint. So we can actually do these injections. They're kind of commonly known as gel injections into the joints. And for some, again, they work for about 3 to 4 months at a time, can provide significant relief and improved function. There are some regenerative injections that are kind of popular these days. I'm not going to spend a lot of time on this because, again, we could spend an entire hour talking about stem cells and platelet-rich plasma and prolotherapy. Stem cells is a treatment in which we actually harvest cells from your iliac crest, so the back of your hip area, with a large needle, and then actually inject those cells into the affected joint. And in some people, those cells, the hope is that they will regenerate into cartilage tissue and will heal your joint in that way. Platelet-rich plasma, or PRP, is a process in which we draw your blood from your arm, spin it down, and we take off that clear coating of the clear layer that's on top of the blood, and we inject that into the affected joint. The hope with this is that it will incite an inflammatory response, and your body will then heal the affected joint. Prolotherapy is a similar technique in which we inject kind of a sugar water type solution, which causes inflammation in that joint, and your body then sends a lot of blood to that area, and hopefully your body will heal itself. These are all considered experimental, and insurance does not cover them. They can be really expensive depending on the treatment, and frequently you need more than one if it's going to work at all. This is what my every Wednesday looks like. Is I do injections under fluoroscopy. So this is a hip joint injection. You can see the little ball and socket here. This is a needle coming in from the side. This isn't a terribly painful injection at all. It shouldn't be. And the needle comes here into the joint capsule. A little bit of contrast here, and we're outlining the hip joint. That just gives me confirmation so that when I actually inject the cortisone into the hip joint, I know that it's going there and not spilling out here. This is another type of injection we do. This is ultrasound guidance. So this is a shoulder joint. This is a subacromial bursa. So if you kind of feel on the outer edge of your shoulder that some people have bursitis there, and we can actually, using an ultrasound probe, I can get an image just like this, and watch my needle come into the subacromial space where this bursa lives and inject some cortisone there, and hopefully, relieve their arthritis pain. The sacroiliac joint is another very common joint to have arthritis, and it sort of sits at the lower aspect of your lumbar spine and the upper part of your buttocks. So some people will come in with point tenderness there. This is an X-ray image that I would get in the fluoro suite of the SI joint, and we can just put a needle there, inject a little bit of contrast, and then put cortisone there, and hopefully alleviate their pain and improve their function. When cortisone injections stop working into the joints or into the affected areas, then we can move on to other types of treatments, namely for knee osteoarthritis, which I treat very commonly. When other injections have failed, we can target the nerves. There's a set of nerves that go to the knee joint specifically. It's called a genicular nerve. They're comprised of the sensory or the sensation branches of 3 different nerves, and it provides innervation to the bulk of your knee joint here. We can actually put needles through the skin into the areas where we know, based off cadaver models, where these nerves live, and actually treat them. We can actually do what's called radiofrequency ablation and actually heat up the tissue right around here and actually burn those nerves away. I actually just finished one about 30 minutes ago, and that can provide tremendous relief for sometimes 6 months, sometimes a year. The little nerves do grow back over time, so the duration of relief is variable, but can be really helpful in people who are trying to avoid surgery, or even people who have already had a knee replacement surgery and are still having pain up to a year afterwards. For arthritis of the spine, we treat that a little bit differently. The facet joints are these little joints here where the arthritis typically is, and we can treat that by targeting the little nerves that go to those joints. Those joints are called medial branches. And this is a picture of when I also just finished one of these this morning, where getting an X-ray image of the spine here. I place needles right along where I know, based on anatomic models, where those little nerves live. And I can actually, the tips of these needles heat up, and we can actually cauterize or burn just those nerves. Those nerves are just sensory nerves. And that will provide tremendous relief of pain to this joint for, we say, a minimum of 6 months, sometimes up to a year or two. It can be very successful when used appropriately. So it's a pretty fun procedure to do. Again, it's not painful. And lastly, when all of the above, everything else fails, we're left with peripheral nerve stimulation. Peripheral nerve stimulation is the new kid on the block. When, you know, in this particular case, I had a patient who had a knee replacement and she still had pain. It had been 2 or 3 years since her replacement, still with pain. We tried to do the radiofrequency ablation of the genicular nerves, and it didn't last long. So what we ended up doing was there's this little electrode that you can see here. It's very, very small, about the size of a guitar string or violin string. And we can, using a needle, I can insert it through the skin and put it down to where those nerves are, where the affected pain area is. And these little electrodes sit underneath your skin and talk wirelessly through your skin to a little device that sits outside. So if you know, I want to go for my 2-mile walk, you just strap on your little device, you turn it on, you activate it with an app on your phone, and these little electrodes deliver electrical impulses to the nerves and actually block the transmission of pain signals to your brain. So it's a little bit more of an invasive procedure. So we don't start with this, obviously, but ultimately, this has helped give a lot of people their lives back. And when all else fails, we do sometimes end up having to go to replacement surgery. This is just a perfect little hip replacements or knee replacements, but we're here to help all along the way, because sometimes even after these replacements, people will end up with significant pain, and we try to help out with that as well. So that's the end of my talk. I think I went a little bit over, but you know, thank you for letting me share with you a little bit of what we do on the pain management side. A lot of people come to me thinking that all we do is prescribe opiates, and nothing could be further from the truth. We try our hardest, and we have some really cool medications and injections and therapy options that can be helpful. And so we hope that you think of us, and that you know if you do have pain or have a problem, we're here to help. And I think that is, and I have my contact information here. So if there's ever any questions or anything,